Suman Biswas to deliver a lecture on SLT as primary therapy in glaucoma. And with that, we can take one questions if there are any. Because as very beautifully derived by Sir, that always we don't have to rely on a single investigational finding. The glaucoma diagnosis, the treatment, everything needs to be in a holistic approach.
Hi, good morning, everybody. Greetings from Burton-upon-Trent in the United Kingdom, the Queen's Hospital, where I work. It gives me tremendous pleasure to deliver this talk on primary SLT treatment, not just because I'm passionate about SLT. I've done a few thousand SLTs over the past 10 years or so, but because I'm delivering this talk in Kolkata, my ancestral hometown. I haven't lived here. I studied in Chipma, Pondicherry before moving to the UK. I remember in 1992, I traveled as a young doctor to attend the AIOC conference in Kolkata. It was at the nearby Salt Lake Stadium. From then to now, it gives me tremendous pride and satisfaction to see how things have changed, not just in the venue and the quality of the programs, but how much Indian ophthalmology has advanced over the years. Coming to the remit of my talk, selective laser trabeculoplasty is now the default choice, and it is the preferred practice pattern, not only in the US and UK, but many other countries in the Western world. I have already noted that ophthalmologists in India are somewhat reluctant to adopt SLT because many feel that it doesn't work. One of the objectives of my talk will be to convince and persuade that yes, it does if done right. I don't have any disclosures to make. Let's look at the background a bit. The glaucoma laser trial was done way back in 1995. It compared the efficacy of argon laser trabeculoplasty, which was what was available at that time, and it was compared to topical medication. The laser treatment was as good as topical medication. That was the outcome of the study. Obviously, we didn't have selective laser trabeculoplasty at that time. Now, selective laser trabeculoplasty was first done in 95, but actually it was Mark Latina in 2002 who really made it popular. The SLT versus medical therapy as a primary treatment was studied in the early 2000s and published by Katz et al. In 2012, and it simply showed that SLT was as good as topical medication. So obviously, SLT was gradually replacing argon laser trabeculoplasty because, as we all know, argon laser does damage by photocoagulation of the meshwork and therefore lead to scarring, and you can't repeat it, whereas SLT is more selective for the pigmented trabecular meshwork, and it acts by laser photothermolysis, and it also doesn't do any collateral damage. It provokes inflammation, cellular proliferation, remodeling of the meshwork, increases the outflow, and thereby reduces the pressure. So the advantage is we can repeat it. So obviously, argon laser gave way to selective laser, and SLT was the dominant laser form. Primary SLT for open-angle glaucoma and ocular hypertension was also studied and published by Garg et al. In ophthalmology in 2019. But it was really the LIGHT trial which came out in 2019 as well, and this was done by Gus Gazzard from Moorfields in London. And it was a multi-center trial. We were all part of the trial at one stage, and that landmark study really brought SLT to the fore because then people started noticing it more, and this study was scientifically very robust. What it did was it compared SLT with topical medication by randomizing patients and then following the outcomes. The trial results showed that there was not only better intraocular pressure control, the glaucoma progression was slower, and that was 3.8% compared to 5.8% with topical medication. Not just that, in systems which have got universal healthcare, like in the UK, cost was a factor because the amount of money that is spent on drops is much more and outweighs the cost of installing a laser machine and doing a one-off laser treatment. The cost savings in UK, I'm giving the figures from there as published, is £451 per patient per year, and I'm sure it'll work out significantly even in India. The follow-up showed that there was a 74.6% drop-free after treatment with SLT at 3 years. And not just that, in the trial, nearly 58.2% achieved that with only one SLT session, which was significant. Sorry, how do I go back? Can you go back, please? Yes, thank you. So what are the advantages of SLT over topical medication? Again, I'm looking at the published literature. Zhou's paper in ophthalmology therapeutics in 2017 showed that 35.9% reduction of IOP was achieved in open-angle glaucoma. In the LIGHT trial of 2019, it was a phenomenal 74.2%. And that was probably because it was mostly a white Caucasian cohort. And not just that, they selected treatment-naive patients. And we know that although SLT can be used as an adjunct to topical medication, it works best when you are having a treatment-naive group and instituting as a first-line treatment. SLT is very safe and well tolerated. It is a very short, intense pulse. It is 3 nanoseconds, and there is no pain, just a mild patient discomfort, a bit of redness, which settles within 1 or 2 days. Sometimes steroids are used, but many times people don't use steroids. And because it doesn't do collateral damage, it is very selective. The advantage is it can be repeated. Usually it lasts for about 3 to 5 years. It varies, but if it is not working and fading away, you can simply repeat it. I have already talked about the cost effectiveness, and it's not just the UK, but studies have been done in Canada as well, and Lee et al. In the Canadian Journal in 2006 did allude to the significant cost savings. In fact, when we were putting in a business case in our hospital, and that was in 2013, I had to demonstrate that, yes, it will be worth buying the machine because the laser machine at that time costed about £30,000. It's about the same in UK even today because, of course, the technology has become cheaper, but inflation has also countered it. So I don't know how much it is in India, but the cost of the machine was, to put it simply, much more recovered within just a year, and within 2 years, we had enough savings to be able to say that to the management that we are actually saving money 3 times over within 2 years. So that was the business case to buy the laser. Not only the cost, but it is also useful in areas where you have limited access to either glaucoma medication or surgery. In some remote areas, patients may not get hold of medicines regularly. And of course, the sophisticated surgeries may not reach many remote areas, but you can bring them just to one center, do the laser, and that might give you some time. There is also the advantage of reduction in reliance on daily topical medication. Patients sometimes get the freedom of not having to do the drops every day. And sometimes there are patients who are always poorly compliant with drops. In that sense also, you can do a one-off treatment, and that's an advantage. So the disadvantages are the IOP spike, which again is very rare and can be preempted by treating beforehand with iopidine or apraclonidine and brimonidine. There is iritis because it can cause inflammation, but that is again very limited. I have already said that it can be repeated, and there are some articles about variability in the outcomes. So there are articles like Beletsky's of 2019, where there has been variable outcomes based on protocol and operator experience, and also Song's paper in Glaucoma in 2005, which says that there was only 60% effectiveness if done over 180 degrees. So what I want to say in conclusion is that the spot size is 400 microns, and it has to be placed centered on the pigmented meshwork. And it should not be either going towards the corneal endothelium or towards the iris, because the spot size itself straddles between the Schwalbe's line and the iris root. And if the plane is correct, if the focusing of the meshwork and the pilot laser is accurate, then it will be confocally delivered. And if done like this, patiently, then it does work. To summarize, we know the benefits from the light study and various other studies. It is a very convenient procedure. It leads to cost savings, and it gives patient independence. So I would say that it is worth a try as a primary modality. Thank you very much for inviting me.
Thank you, Dr. Suman Biswas. That was a good exposition about SLT.
I just have a little comment to make. I've got a lot of experience with SLT myself, but like you said, I have not seen results of SLT last for over 3 years. Between 3 and 5 years is something that we've just never seen. In fact, over 18 months, between 18 months, we have to keep a repeat follow-up to make sure that they need medications or they need a repeat SLT. And the effect that you get post SLT, repeat SLT is much lesser than the result that you get the first time you do the SLT. Also, SLT, if done in a naive eye, gives you much better results than if you do it on a patient who's already on medication. So that's, I think that's a big take-home message for people, because if patients are already on medications, then taking them off medications and giving them SLT is not a very good proposition. And hence, I think, the Indian continent or maybe the Asian subcontinent is not in such a big favor of SLT.
Can I respond now?
Yeah, you can.
So what we are trying to say is that it is to be considered as a primary modality, not as an adjunct. And if you are choosing as a primary modality, it will only work in some cases of open-angle glaucoma, most cases, and ocular hypertension. So for instance, primary open-angle glaucoma is fine, pseudoexfoliation and pigmentary glaucoma is fine, not so much for uveitic open-angle glaucoma or steroid-induced glaucoma. So that's the case selection. But the main difference comes about if the technique is done properly. Because I didn't have time to elaborate, but I politely tell off my trainees who will finish doing SLT in 10 minutes flat. Because it's impossible to do 90 to 100 burns over 360 degrees without being very meticulous and with attention to detail. It is not like a yak capsulotomy. So if it is properly focused, and if you see the champagne bubble reaction in 50% of the doses delivered, the main thing to achieve that is by modulating the power as you go along the angle. My preferred practice is I start with the inferior angle with the reflector mirror on top, and then I keep the power down because we know that the pigmentation is more in the inferior angle, and then I step up the power to see the champagne bubble and then go sub-threshold where there is no reaction. But every few bursts, maybe every second or third burst, I step it up to see the champagne bubble again. And for the champagne bubble as well, if it's a huge stream, that is a bit too much power. Of course, if you get a white spot, that is not SLT, that is more like ALT. So the champagne bubble has to be just a little hint and then sub-threshold, and like that, 50% of the bursts all around have to have the champagne bubble. That is the kind of meticulousness. If you have got patients like that, even then 10% in my hands don't work. So how I do it is I try with one eye at a time, and if it works in one eye, I go on to the second eye with full confidence. If it doesn't, then I rely on topical medication. But also I always, when you see the patient in the clinic for the start them on a prostaglandin and then schedule the SLT. And SLT takes some time to work, we know. So after about 2 months or 3 months, if the SLT has dropped the pressure enough, then I stop the prostaglandin. So that's my practice pattern. But there are many patients in my hands who are drug free. Thank you.
Thank you,
Thank
Dr.
you.
Suman.